Good afternoon, everyone. My name is Scott Fontenot. I lead our Central Pain Syndrome Foundation. Excuse me. The reason I say ours is because those of us who are part of a patient advocacy foundation are all volunteers, and we're folks who have been afflicted ourselves so far. We have caretakers who are not afflicted, except for the fact that they care for others. But my name is Scott. I help lead a foundation that serves the interests of those who have central pain syndrome, and we'll talk about what that is briefly. This is our third month that we've had a 1-hour discussion. I'm not very good at taking questions yet off of the internet, so what I'm trying to do is give a basic 4 or 5 hour talk about what I know in a very broad way, so that when a person comes either to our site at Facebook or we're opening a YouTube channel, when folks come to those places, they'll be able to see video 1, 2, 3, 4 while they're walking around the house. They can listen and learn at least as much as most of us do, as much as I do about this. I'm not a doctor. I'm a researcher and a layperson, and because I have it, I want to help others avoid it, and so do all of those that work with us. So welcome. That's who we are, our foundation. I want to mention just a couple things, a little bit of news before we get into what we're going to talk about today. What I am going to talk about are the causes. What are the causes of CPS? What makes people have this terrible burning sensation in part of their body? What causes that? And interestingly, when you break it down medically, there are something like 70 causes, or etiologies they're called, and we'll get into that. But let me mention a couple things. We're beginning to do some research together, preclinical trials it would be called. A clinical trial means it's all very formalized. You have a control group who don't get the medicine, or they get something that looks like it, but it's not really the medicine, the placebo effect. And then the other side actually gets the medicine, so that they compare how each one did. That's clinical trials, right? And we're moving into that, hopefully, but it'll take a few years probably. But we can do what are called preclinical trials. That's where we get a little bit organized and we find something that we want to try out, and then we try it out together a little bit by talking about it as we use it. Something I found very useful is an application, actually, for learning cognitive behavioral therapy. It's something I believe in. Most of us who have been to psychologists and so on, we hear all about cognitive behavioral therapy. Now my screen isn't lighting up. I was going to show it to you. But anyway, there's an app out, and it was put together by some very smart people at Oxford, psychologists, computer scientists, and so on. And basically all it does is it takes some scripts and some algorithms and graphics, things that an app is made out of, and it teaches us and helps us to apply cognitive behavioral therapy. So basically, I check in the morning, and it's like I'm talking to my robot counselor, and it's okay. You know, you can say anything. It's very very low key, very objective. It's a good little tool. So, but what he does is he asks you the same sort of questions based on what you're saying, picking out the key words, and it's a very interesting tool. So what we're doing, a few of us, is we're taking this cognitive behavioral therapy app, and we're just checking in, and we're just, playing with it. It's like a toy. I'll just talk to the guy. He'll say, like, what's the problem? And I'll say, man, pain. So he'll say, let's talk about that. All right. Anything I can do what can I do to alleviate the pain? And he'll offer me some choices. One of them is meditation. So I click on meditation, and he helps me to do some breathing, to focus on my breath. He helps me to just go through a few moments, just 5 moments or so. And you'd be amazed by having this little tool, this little calculator with a human voice help out. He helps me to stay focused on the things that I'm trying to learn. So what happens is, by practicing cognitive behavioral therapy with the tool helping us to know what to do, pretty soon we ask the right questions and we start thinking a little bit better the right way on our own. I think that dealing with chronic pain, we all face a lot of mental issues like depression. Some of us, because of brain injury, we have other sorts of mental issues. So anyway, this is a tool to help us kind of get a handle on our feelings, our emotions, our thoughts. And what I'd like to do is, if you're interested in doing this, you can private message me, but download it. It's called Woebot, WOEBOT. If you have an Apple phone, go to Apple Store, Android, it's there. Download Wobot. It's really easy. You just log in with your email password, start messing around with it, and see what you think. Then we'll probably open a discussion group, which is if you tell me that you got it, you want to talk with other people, then I'll just form a little discussion group and we'll figure it out. And here's what we want to do. If 5 out of 10 people say, yeah, it was good, 3 say it was totally boring, because it is. It's rather, it's very mundane. It just uses a program. But anyway, we'll get some opinions on it and then maybe offer it as a tool that folks who are struggling with depression or they're struggling with emotional expression, emotional distress is an issue. Like we get into a social situation, our family's around, and we're in pain and we can't handle it. I just go in the room. I'm messing with it, and I just kind of go, okay, let's see what Wobot says. And just, he asked me some questions and I make some answers. And here's how it works. I was going to tell you, we have these crazy thoughts. Like, I'm a terrible person. Every time I do this, it falls apart. I can't deal with this pain anymore. So we have these just extravagant thoughts, right? And so what we do is we kind of write those down. We kind of just spell them out. And then what happens is we take some rational answers, like, is it really the end of the world? And you kind of think about it and you go, well, no, probably not. Are you really never going to do anything of value ever again in your life? And you think about that. That's the question, the logical response to the emotional craziness. You kind of go, no, actually, I'll probably do something good, once or twice. So that's what happens. We have these emotional outbursts. We ask some rational questions back. It has something called a gratefulness journal where you just write a line, just not more than a line or two. It also has some other tools where you can watch a little animated video to just get a little handle on things. So we're suggesting a WONET. Try it. And let's spread the word. I'll keep asking people. We'll see if we get maybe a handful of people, I'm hoping for, maybe 4 or 5 who are using it, and we'll see what happens. Then, secondly, this is the 3rd year that we're going to take our CPS annual survey. So 2019, we did the first one, 2020, the second one. This will be our 3rd one. The reason that it's important for this to be annual is because we're trying to build a database based on mostly the same questions so that we can see, are more people doing this? Are fewer people doing this? Are most people feeling this way? Or are some people feeling this way? And the survey allows us to see these things. What we're being able to do is offer to neuroscientists and to doctors and all kinds of folks, even those of us who are patients, but scientists, and I'm beginning to really push this among neuroscientist associations. Hey, we have 2 years worth of data on how people feel on the most important questions regarding central pain syndrome. And if you'd like to know about that, here it is in a PDF format, and then we can sort of talk about other things. You may have heard that the Harvard School of Statistics took our data, and we're working on a little project with them. And so what we're trying to do is build up the data. We'll be able to show you graphs of how things are happening. For example, more people are using cannabis, we know, and people are using opioids at the same level. We can tell what drugs most people are using pretty good. There's some issues, but anyway, the 3rd annual survey will be up in the next few days. This is the most important thing. And the second year, we had fewer people than the first year. And I think the reason may be simple, and that is some folks feel like that if they've already taken it once, that's it, But what we want to do is have everyone, as many people as possible, take it every year. If there's a way I could email you, we might collect email addresses, because if we can get more people doing it more often, then it becomes sort of the most valuable pile of data on the planet, basically, about central pain syndrome. And so as we move along and work with, we're working with neuroscience institutes, starting with the Paul Allen Neuroscience Institute here in Seattle, right across the water. I can take a ferry and Uber and be there. And they've offered us a personal tour of the place. And we're going to talk about what they're doing that affects central pain syndrome, and then use that as sort of a template for other regional, especially MRI radiology places, but folks that are doing research on our problem. So take the annual survey. You'll see it in our group. And I just encourage you to do that. And I'll have some reports and some analysis of the second year coming out soon. And I've got to check my watch because I'm usually behind schedule. We're doing pretty good. 10 minutes on announcements. I think that's about all. Oh, there was one other thing I wanted to mention. I've got to slow down and relax. How's everybody doing? I hope you're having a good week. Mine has been interesting. If you follow along in the group, you know that I slipped and had a little concussion last week. And I got a boat I've been waiting for 20 weeks. Can you imagine ordering something nowadays? Usually Amazon, which is about 13 miles, they have a huge warehouse near my house. The next day they bring my stuff. Sometimes that day, hardly ever more than 2 days, but I waited 20 weeks and I got a boat, and I can't wait to get out in it. But it's been interesting. So I hope you have a good weekend. And but there's one other thing I want to mention. We were just talking, not just with men, but also with some of the ladies in our group, about how sometimes it's difficult for us men to express ourselves, how we deal with pain, how we deal with some issues in life that are rather personal and intimate. But what we're trying to do is help men, first of all, make friends with other men. I've mentioned this, something we learned from our survey, and that is in our Facebook group, about 70% of us are female and only 30% are male. And the reason that's important is because in the real world, it's 50-50. So, somehow we've got to find a way to find more men to survey, for one thing, but it also means we're not doing our job as far as reaching men. So we just got about 5 or 6 guys together and we talk and we share. We do that personally, but by doing it together, guys are getting to know each other. And what we're doing is starting to talk about some of our issues in a little separate group. So if you're a guy, you're interested in that, again, you can let me know and we'll talk about that. And the guys are leading the group, which is really cool. And think of it as sort of a men's support group. Now, I want to make a really important point on this. I consider the main group like a public group. In fact, we have a sister group that is a Christian group, you could say, because that's part of what they do, right? Faith. Okay, so I don't want to have a bunch of different groups, but I think a men's group is unique and useful because it'll help men have a place where they can go and talk. If a cuss word comes out, I don't think the other guys will get too mad, although I put little beeps in mine, right? But just where men can kind of feel a little bit looser to share and then hopefully attract more men even to the main public site. So I keep telling men that come to the discussion, hey, this is just one little private thing. Stay involved in the big group because that's important. Let me just look real quick. I'll mention who's watching, okay, because this is live and we're learning how to do this. I see Steve, my good buddy in Chicago. He's part of the group. Linda Hamilton. Brandon Walsh and I have been talking a little bit. I'm learning about Brandon from, he's in Colorado, I think, and I won't go any further than that, but a few people are watching and that's nice. All right, so men, think about coming and discussing some stuff. Just you can come and read all the goofy stuff we're talking about. We post cartoons that are for men. Okay, they're not bad or anything. Just, we have a crazy sense of humor. All right, so I'm going to get into what I wanted to talk about a little bit. So those are a few things I hope that you remember. We have a little men's discussion group just starting. We're trying to figure that out. We want that to be a group, maybe even on a different platform where we can post things and attract men sort of from another world into our Facebook group and CPS Life. So men's group. And we're also working on the annual survey, and then WoNet, a little app you can use to help you with. It's called an emotional assistant, and I found it helpful so far. I'm going to keep using it for at least 2 weeks, maybe a month, while we discuss it, and then after that, it's up to each person, and we'll just write some discussion and things like that. So what I want to talk about today is a very important subject. In fact, we'll probably spend a couple of sessions on this. We're moving through maybe 4 or 5, maybe 6 discussions or lectures where we talk about the main things. So we introduced who we were and our Facebook group and how that works with the foundation, some of the things we were trying to do. We introduced what CPS is, just in case someone picks that particular session briefly. And we began to talk about just our survey. We went over the survey carefully in our last session. And now we're going to talk about what causes CPS. And then following that, we'll get to the juicy part, which is treatments. And we're going to really take our time on treatments. There are about 25 treatments that we could say in the CPS textbook, there's been a study done, say for acupuncture. And we can say, okay, there's been 1 or 2 studies done on acupuncture, and we know that it's kind of like this. So we're going to build a catalog where there's 25 things that people have either tried, like ketamine infusion. 5 people tried it. 3 people had some success. 2 people didn't do anything. 1 person had hallucinations, different things happen. So we want to try and catalog that, build it up so that we could tell someone like a doctor, hey, we've had 50 people try this and here's what they said. And then, so we have a catalog. And then when people look at it who have CPS, they can say, I'm going to try that. Maybe I'll try that, get in the pool and do some stuff. So we're going to talk about treatments last. All right. So here we go. I'm going to try not to talk too loud. I'm losing my voice. It's been a busy week. I slipped in the tub this morning, which is quite humorous in a way, but I want to talk about what causes CPS, what's important to know. We'll just kind of go, if we run out of time, we'll just pick up next time where we left off in the 70 etiologies. So CPS is not a primary illness. It's not like getting Parkinson's or cancer or something where there's a germ or an illness or an infection that is attacking the body. CPS is a secondary sort of illness, which means that there will be some sort of bad thing that happens, like a stroke. And then as a result of that, oh, you can see my scar. As a result of that, central pain syndrome happens. And so there's always a specific cause. And so what we want to talk about today is what was the original injury? What was the illness or the damage that led to CPS? We're going to try to take our time and really talk about that. And so let's start with the brain. And the reason I say that is not because I had a stroke, but because in our survey now we see, and research shows this as well, about half of us, about 50% of the people in the world who have central pain syndrome, at least in the United States for sure, we'll work on some other countries as we go, but it was something that had to do with the brain, with a stroke, with a lesion. Something bad happened in the head, and that caused a person to have central pain syndrome. And so that's the big one. We're going to talk about 5 things if we have time. These are the 5 major categories of illnesses that cause central pain syndrome. The first is lesions. And a lesion, we think of it as a stroke, but if there's a lesion, which is some tissue gets messed up, if there's a lesion in the brain, it's called a stroke. But you could have lesions in your spine. You can have lesions anywhere in your body where the tissue gets messed up. That's a lesion. We're going to talk about trauma, pow, or boom, bullet goes in, penetrative. We're going to talk about trauma. We're going to talk about inflammation. The brain swells up for a lot of reasons. And when it's finished, it can cause a person to have brain damage that leads to central pain syndrome. If we get to it, we'll talk about infections. And then, that last one is so nice. We'll talk about tumors in our time together. All right, let's talk about the brain. And then next week, I wanted to say we'll talk about the spinal cord, because 50% of us have brain and stroke issues with central pain syndrome. But then the second largest group would be spinal cord injury, SCI. Folks with all kinds of spinal cord injuries end up having this burning central pain syndrome. It means that either their brain, their brainstem, or their spinal cord were injured, and that's causing the terrible chronic intractable pain for most of us. All right. So in the brain, what happens is, some really bad things. In the United States, we'll just talk about, because that's the easiest data. I like global data better because we want the work that we do to be spread so that it has more value. Just under 2 million people is my current guess, my educated guess in the United States, and probably something like 20 million around the world. But in the United States, there are 795,000 people each year who have strokes. About 600,000 of them, that will be their first stroke, and about 185,000 people will have a repeat, their second stroke, every year. So that means about 660,000 people in the United States are stroke survivors every year. And what I find interesting about this is that people who survive tend to be younger than people who have strokes when they're older. So 75% of the strokes in America happen to people who are 65 years or older. So those of us who had our strokes when we were much younger, mine was 41, 36 for a TIA, but then 43 for a stroke. But anyway, what happens is we tend to survive because we had the stroke when we were younger, more vigorous. We weren't older and with all the other complications. And so 660,000 people survive every year. Now, that's good. People are surviving. More people are surviving in places like China, where they're able to improve their medical care for neurological things. But here's what happens. About 8 or 10% of that 660,000 here, I think it's much more like 1.2 million people around the world would be included. 8 to 10%, 55,000 people a year will have a stroke out of that 660,000, and they will end up with central pain syndrome. So about 10%, 1 out of 10. You take 10 people that had a stroke and you pick out 1, they will have central pain syndrome. And so it's about 10%. That's a really high number. This is not a rare disease. We're listed on the Rare Diseases website because that gives us some access to clinical trials. But the definition of rare disease, central pain syndrome, doesn't meet because it goes way beyond 200,000 cases. We're talking something that's more like, it's a big deal around the world. So an important distinction. After a stroke, about somewhere between 10 and 55% of all the people that survive strokes, you have this, let's say 700,000 people survive the stroke, 600,000 people, 10 to 50% of them have some kind of pain. But the fact is, most of them experience chronic pain more than 6 months, but it's musculoskeletal pain. I have to look so I pronounce it right. It's nociceptive pain, right? So people have strokes. A big bunch of them, maybe 1 out of 3, have some kind of pain that lasts a long time because strokes are bad. What happens is you have the stroke, then you kind of can't walk right. A lot of people have real bad shoulder issues. There's a whole, I can't remember the name, but I'm sorry. There's a whole syndrome that goes with stroke and shoulders. So people have that pain, right? So there's all these musculoskeletal pains that can be a lot like central pain syndrome that people have, but they're not. It's a distinction that we really need to be careful to make. There's a lot of things that feel like it, but here's the difference. If my shoulder hurts because of tendons and bones and everything but nerves, then that's not central pain syndrome. But if the shoulder hurts because there's a problem with my spinal cord, and then the nerves that come out are carrying this bad information, that's a different thing. It's the same feelings, but it has a different cause. And so it's why we estimate that, of all these different kinds of CPS, these 55,000, stroke survivors, and I'll just make it last year, in 2020, there were something like 60,000 people who got CPS just because they had a stroke. Now, that wasn't the total number. That was just one piece of it. That was half. So something over 100,000 people got CPS last year. About half of us got it because we had a stroke and the stroke hit in the wrong place, right? About half of us. And so those people will live, I'm thinking, and we're working on this prevalence and then how long they'll be around, but just say an average of 10 years because that's how long stroke victims live, although we're younger, so we tend to live longer, but that's why we think that there's something like 2 million people, because when there's 55,000 more every year and they're living 10 years, that's 550,000 people. If they're living 15 years, that's 750,000 people. So we're running different algorithms in our research programs, and we're trying to get all this stuff dialed in the right way. But I think out of 660,000 stroke survivors, about 50,000 because of a stroke have central pain syndrome. When I tell people this, sometimes they find it hard to understand. Sometimes they think I'm exaggerating to try and make it bigger. But I want you to know, as a researcher, I pride myself as a demographer. I worked in Asia for a long time, but making things conservative. So that means if it's 8% to 12, we go closer to 8, maybe not all the way down to 8, but 12. Sometimes it's hard to tell. So you got a pretty good guess from clinical research, but then you just, you find out where in the guess you feel comfortable. I feel comfortable on the low end, okay? So we're going to find out there's probably a lot more people. It just hasn't been studied correctly because it's not a disease that you can just name like Parkinson's. It's something where there's 70 different diseases that lead to it. So that's the issue. All right, so what happens then is there are lesions in the brain. There are vascular lesions. Usually it's an ischemia because about 70% of all brain issues are ischemia. An ischemia stroke happens because blood stops going to part of your brain. So over here, they were doing some surgery. They made some snips. They fixed things. But when they closed me up, blood started to stop going to a part nearby, and a little round circle died. And so that's a stroke, right? It's because blood isn't going, in ischemia. And then the other kind, which happens 30%, is kind of more dramatic. It's a hemorrhage. Hey, there's Mark Miller, I see, and there's Matthew William, a young fella. I was going to ask you, Matthew, if I could mention about you because it's interesting. I'll just say this because he's told us this. He's a young man who is a boxer and an athlete, and because of traumatic injuries to his head, he's facing central pain syndrome. The reason he's so important to me, Matthew, I'll just tell you, I want to be buddies because it's a small percentage, and we don't have anyone who's come out yet. But Matthew and I together, I think, will learn a lot for all the guys that come later. He has been diagnosed with CTE, which we'll talk about. It's very difficult, friends, at his age. And so just hang in there. Get to know Matthew. He's a cool guy. And but anyway, so strokes. Hemorrhages. It means it busts open and there's bleeding in there. And it can be quite dramatic. Usually it's bigger than an ischemic stroke. And so strokes happen independent of surgery. They just happen, but they also happen due to spasms or infarction, or there could be a direct brain injury. Somebody cuts wrong. But these are how people have strokes. And so one of the things that we have to watch out for would be stroke symptom spasticity. And again, this is how we confuse central pain syndrome with other kinds of pain. We have spasticity because we had a stroke. I have it, and I get Botox for it. It means my muscles are tight. There's tone to them, but also when the doctor moves them really quickly, the tone will even tighten up more. So when I lift up my leg to put on my socks, I have to work harder on the right side than I do on the left side. That's spasticity. It gets tight and it hurts really bad. It can drive you crazy, but you can have that without having central pain syndrome. It can be caused by central pain syndrome or not. And so we have to look out. Central pain syndrome will have obligatory sensory deficits that help us determine that it's not just that I have spasticity. I have a lot of other things going on. That's a hard word for me to pronounce. Spasticity. There we go. Secondly, and now we're talking about lesions, okay? Bad spots in the brain that cause us, they're on a network, and that's really important to understand. There's a spinothalamicortical network. It's the spine up into the brainstem area, and then the thalamus, and all the way up into the prefrontal cortex. There's this network that does a bunch of stuff. And what we've learned is, it used to be called a thalamic stroke, right? It used to be called the journée russe because they were the French doctors who discovered it back in the middle 19th century. But anyway, it was a thalamic stroke because it was always in this area. Now they've discovered that it can be a lot of places on the network, even, a lot of places on the network. We're talking about brain lesions. It could be in a lot of places in your brain and still cause central pain syndrome is what we've learned. It's on a network, not on a hub or a spot. And so there's a lot more to learn about that. All right, the next thing that happens after lesions is vascular formations. I spent a lot of time on that because, like I said, half of us are here, half of us have central pain syndrome because we had a stroke and it didn't turn out well. Vascular formations are all kinds of blood vessel type things, and we're talking about vascular things, right? We're talking about things that have to do with the blood system that cause central pain syndrome. But vascular malformations is what I had. It's a cavernous hemangioma. It's a blood vessel that's going bad. There's all kinds of different versions of these blood vessels going bad. It can cause a hemorrhage. Mine was just very small, little, almost, they're not microscopic, but the thing started out the size of a pencil, but it got the size of my finger because it's expanded 3 times. So these walls of the blood vessels, they let out some blood, just a little bit. It hardens like a little scab. Then they let out some more blood, hardens like a little scab. And people have these and never even know they have them. Like tons of people have them, cavernous hemangiomas. That's because it's not in a bad place. If it's in a bad place, if it's in the white matter, like they can cut out part of your brain for epilepsy, right? They take a big chunks out of their lobotomy type things to keep people from having seizures. But if it's down here, anywhere in the subcortical, then it's a lot bigger deal down there. And so a bad blood vessel is a vascular malformation. And that can actually cause, and so what happens a lot of times, there's compression. So the malformation, the blood vessel grows, it presses on something wrong. All of a sudden, the central pain syndrome happens because there's a network that's programming the sensory information. It tells you kind of where your hands are, your elbows, it tells you things like that. How are my elbows? What angle is my body at? There's that. There's all kinds of things going on. And when it gets disrupted, all of a sudden, we do kind of bad on some of those things. And the worst thing is, things that touch us and shouldn't bother us at all can drive us into a very bad place. You all know about this that's watching. It's kind of funny. But this is going to be on YouTube, and people who've never heard of this, their doctor's going to say, look up a thing called central pain. That's what we're talking about. And so there's lesions, and then there's vascular malformations, different kinds that sometimes they have to be taken out. Sometimes they bust and cause a problem. The third thing I want to talk about as far as vascular things would be migraine-induced vasospasm. So think about it. It's a terrible thing. I had migraines for 10 years. That was all being caused by this thing in my brain. But people actually have migraines where migraines usually tighten up the muscles on the outside of the head because of nerve things that happen. On either side, the trigeminal neuralgia, there's a nerve hub right here. That's why if you get a bad headache, just kind of rub the nerve. I do head massage I'm a masseuse, right? But anyway, just kind of rub these nerve hubs. Anyway, um, uh, migraine can start, and it can be so bad that not only does it constrict on the outside of the skull, but it begins to constrict just on the inside of the skull. And by constricting on the inside of the skull, it actually causes necrosis, which is neuron cells dying. So terrible. You could have a migraine bad enough that it causes you to have a stroke. It's rare, fortunately, but what a terrible thing. So that's lesions in the brain. 50% of the people have something like that. They had some kind of blood vessel. They had a stroke of some kind, an ischemic or hemorrhagic, and I wanted to take lots of time on that because that's the main deal. Next, let's talk about trauma, okay? Trauma to the central nervous system, especially traumatic brain injury, is something that we're just learning is causing lots of central pain syndrome. Before things were happening in the football world and before things were happening in the military with wars that have gone on so long, we didn't know a lot about what concussive damage to the brain actually did. Now we're learning a lot about it. And we're learning is that for central pain syndrome, about 1 to 2%, about 1 out of 100 people who have a really debilitating traumatic brain injury will end up with central pain syndrome. And the interesting thing about that is, again, there are these big piles of people out there that are hurting, like vets, a bunch of them, and they're not identified with central pain syndrome because really what they're suffering from is some kind of, generally it's a non-penetrating trauma. Okay, so when we're talking about trauma to the brain, there's two kinds. One penetrates the skull. That's nasty. Let me tell you, that's nasty. If anything penetrates your skull, that's a bummer. that means it's probably not gonna. It's not an easy day. Even if it's a neurologist, that's not an easy day, right? Then there's non-penetrating trauma. And that could be anything from, a concussive device being this close and going off, or a large concussive device that's farther away, but bow, the boom of it, bam, hits me, knocks me down off my feet, does something really bad to my head, concussion plus, and so on. And so what we find is in America, there are about 1.5 million people. I had some tea, but my voice is scratchy. It just means it's been a busy week, but about 1.5 million people have traumatic brain injury every year in the United States. That means about 230,000, about 1/6 of them are hospitalized and survive. Most of these non-penetrative traumas are not a big deal, right? If there's a penetrating thing, it's just like everyone who has surgery. They have to do something to fix it, or it heals up maybe. But something bad happened in your brain, and you might have CPS, 1 out of 100, because that penetrating thing was in the wrong place. When it's from the outside, boom, this non-penetrating trauma, it's very difficult to diagnose, for one thing, because a person may not have the lesion, the stroke marks that mark for stroke and make it easy to say, well, he had a stroke, so it's probably central pain syndrome, or she did. With a non-penetrating trauma, it's harder to find out. But about 230,000 people survive the brain trauma. A lot of them just like, hey, I had a little concussion. I just went to the urgent care. It was no big deal. Or even nothing like that happened, just a trainer, and we go on, right? But about 3,500 to maybe 22,000 people, probably out of that big number, 1.5 million, then 230,000 of them, it's so bad they go into the hospital. Then out of that group, and it depends again how we use the percentages, and we don't know enough yet, but it's somewhere between, like 8% all the way up to 30%. But there could be as many as, I would say, let's say 10,000 people a year. And I do say men for a very specific reason, but 10,000 people a year because of traumatic brain injury are getting central pain syndrome. Now, the reason I want to say men is this, and it's obvious why. About 75% of the really strong spinal injuries, for example, happen to men. And a larger percentage of traumatic brain injuries happen to men. And that's just because of the careers and just sort of the traditional things that men do, like mining and construction, the military. These kinds of careers leave us open to having things explode in our head. All of us could say, yes, and I did stupid things. I was in a rock band, and I could give you the list. I don't even tell my doctor because he would just shake his head. But I climbed mountains and had my head hit rocks while I was on cliffs, and things didn't go right, So, but so there we go. Now I want to talk about chronic traumatic encephalopathy for just a minute. CTE has been really featured by JAMA and others, and it's now known that repeated traumatic blows to the head, not necessarily a concussion, not even a blow so bad that the doctors would say, yeah, you had a concussion on that one. It's kind of bop, bop, bop. Guys playing football, bop, bop, no concussion, just, tapping. They don't do it in practice anymore, but just tapping, tapping. Now they know that alone in certain people could cause CTE. Concussion makes it much more of a chance that that's going to happen. CTE is a neurodegenerative disease. Let me read it for you. It's linked to repeated blows to the head. The symptoms include behavioral problems, mood problems, problems with thinking. It gets worse over time, can result in dementia. And there's some thought in some early research that the suicide idea is strong. Now, the interesting thing is, I'm not diagnosed with CTE, but I am diagnosed with behavioral problems, mood problems, problems with thinking, worse over time, dementia, some would say, yes. And then, going ahead. So there's a lot of crossover. But the point is, there's this whole new pile of people that are being discovered because the CTE research is going on. So if they find 1 million people, we know it's 1% of them. If they find, 2 million, it's 1% of them. And this is why I want to reach out to men, because I think there are going to be scores, scads of men finding out, hey, that thing going down my leg, that burning thing, that's not sciatica. That's because, boom, I was in the artillery or whatever it was. They used to call it, they used to call it just all kinds of things that weren't very medical. All right. So we're talking about CTE. People get out of the hospital and trauma. And so about 50,000, about 20% each year, no one's counting yet, but about 20%, I think, of people that have these traumatic brain injuries of this really radical kind will end up with CPS. In the third edition of the textbook on CPS, they finally begin to mention trauma as a cause of CPS. And they said themselves, the doctors who wrote the textbook, that they're going to find a lot more as time goes on. And that's why I'm saying it. Hi to Gail. She just kind of tuned in, and I'm trying to get better at letting people know what we're doing, but we're trying to record these so we can put them here and also at YouTube. So new folks, when they come along, if they want to know all about it, they can listen for a while if they can handle listening to this gravelly voice and learn a little bit about it. We'll get some more people talking. That's one thing I wanted to mention. We're going to have some interviews with our doctors, with Dr. Lee, my osteopathic neurologist, Dr. McMakin on FSM, and Dr. Tennant on hormonal pain treatment. I'm working on that, having where we interview our doctors for an hour, where you ask questions and all that. What we're trying to do is have 4 or 5 videos that lay a foundation. What is CPS? So we're talking about trauma to the brain and folks ending up with CPS, maybe 1 to 2% of them. And that's a huge new number of folks. So we talked about lesions now. We've talked about trauma. Let's move on to inflammation. Let me check my clock. Oh, we have time for inflammation. Inflammation would include some very important things and groups of people that are amongst us. The first would be MS, or multiple sclerosis. Multiple sclerosis is a terrible disease where the immune system begins to eat away at the protective layer on the axons of the neurons. So you've got this neuron, it's got all these little snaky things going out. It might be connecting with thousands, even tens of thousands of other neurons, right? The axons have this fat around them, and myelination is what covers these nerves. Well, demyelination is a number of diseases that take the coating off of the nerve. So Parkinson's does it, MS does it. The largest group of people we have with CPS would be with multiple sclerosis. And so in that population with chronic pain, they would have some musculoskeletal and nociceptive pain from low back. They have low back pain, they have joint pain, and about 20 or 40% of them have those non-central pains, right? So they're having things that feel like what we have, but they're not from central pain syndrome. They're just regular joint pains. But probably out of that 20 or 40%, at least that many, and let's stay on the low side, scientists who are studying this are saying that probably 1 out of 5 or 20% people who have multiple sclerosis here in the United States and around the world will have central pain syndrome. So that's another big chunk of people. So we have 50% of the people with CPS in the world. It's because of a stroke. about 25%, and we'll get to spinal cord injury, about 25%. That's the next largest group. It's because something bad happened in their spinal cord. But then the third largest group starts to be groups like MS and Parkinson's, because in the United States, about 1 million people will have multiple sclerosis at a time. So there's 1 million people with it. About 300,000 people have multiple sclerosis, but they also have central pain syndrome. Last summer before last, when I did the triathlon, I was able to spend a day in front of my cannabis dispensary handing out bottles of water. It was a hot day, sitting on my trike, handing out bottles of water, telling folks what we were going to be doing, and telling folks about central pain syndrome and our foundation. It was interesting. I was counting how many bottles I gave out. Gave out about 80 bottles. And out of that number of people, I talked to a significant number who had, when I asked them, hey, have you ever had some kind of burning pain? They said yes. But there was about 2 people that said they had multiple sclerosis, and they were there at the dispensary because that was part of their treatment regimen, just as it is mine. A couple of them logged into our Facebook group and website because we share a huge number of people with multiple sclerosis. So one of the things I'm working on is making contact with leadership in these other organizations. Multiple sclerosis has tons of organizations. Some of our folks are helping me make lists of people and contact them. I'll be traveling and meeting with these folks, hopefully, so that we can really connect, and we can help folks with MS know more about CPS, and we can help folks that have MS and the CPS thing, sort of a liaison. But MS is a big thing that causes inflammation and causes central pain syndrome. Then there's something called, I wanted to say 2.3 million people globally have multiple sclerosis, which means there are something like 700,000 people around the world who have central pain syndrome because of multiple sclerosis. So you see, friends, when you start doing the math and keep your algorithms as conservative as possible, if the people who did the research on MS are right, this is a study that I can show you, and I'm going to make a copy of what I'm reading from, right? Only make it much better, much more information of the 70 things that cause CPS, and I'll put links to all of the studies that we're using to make the statistical claims that we're throwing around, right? So anybody who wants to, scientists, doctors, but they say, hey, you've got MS and you've got this burning thing in part of your body, you can dig in and look as much as you want. Or you can look down the list and go, oh yeah, MS is on the list. That means I probably do have central pain syndrome. It gets really complicated with spinal issues because there's so many ways. We're going to spend maybe one, maybe even 2 sessions just on spinal issues, not because there's more people that have it, they're 25%, but there's a lot going on. Sjogren's syndrome is a long-term autoimmune disease that affects the body's moisture-producing glands. Isn't that strange how the moisture-producing glands get affected and you end up with central pain syndrome? The reason is because it seriously affects other organs in the body, such as the lungs, the kidneys, the nervous system. You have to produce some juice for those things to run, right? It has to be the right stuff at the right rate with the right chemicals in it. And what happens, so the glands begin to get attacked. They begin to put out the wrong thing for the organ that they're hooked up with. So there will be dryness and pain and fatigue. There will be dry skin because your skin gets moisturized from within. It's amazing how all that works. Just all kinds of dryness, coughing, numbness in the arms and legs. And although we're not sure why, the exact cause is unclear, it's a combination of genetics and then most likely an environmental trigger such as exposure to a certain kind of virus or a certain kind of bacterium. So you go through some kind of bad thing with a virus or some kind of bacteria, and then you have this dryness because your glands got affected in a bad way, and then all of a sudden you begin to have nerve issues because of all this going on. It can happen independently of other health problems or because of a connective tissue disorder. There's a lot of things that hit just tendons, Beal syndrome and others like that, and it begins to affect the tendons and they dry out so they don't stretch. So a person can't move their leg to 90 degrees, it only goes 60 degrees, or their arm, it won't open because there's no lubrication on the tendons, right? And rheumatoid arthritis, lupus a lot of times will lead to Sjogren's syndrome, and the inflammation that results damages the glands, and so a percentage get the disease. I think it's a low percentage. Let me see if I have that in here. I don't, but it's a very small percentage. Like of the people that have Sjogren's, just a small 1 out of 100 will end up with central pain syndrome because it gets so bad. There's some kind of nerve damage. All right. Then after lesions and trauma, after all these wonderful things, we come to lesions and trauma cause central pain syndrome. I have to go back and look at my notes because my brain doesn't work very well. And then we talked about inflammation, lesions, trauma, inflammation. These cause a lot of the central pain syndrome. But after inflammation, we get to another wonderful thing, which is called infection. So we have lesion, we have trauma, we have inflammation. And now with about 15 minutes left, we come to infection. Infection would be something like 4 out of 100. 4 people have these kinds of infections that I'm going to talk about. 4 out of 100 will end up with central pain syndrome. This could be an abscess. So all the things we talk about, a cyst, an abscess, a lesion, these are very generic medical terms, but it depends where they hit and how they hit that causes central pain syndrome, right? But an abscess like toxoplasma, so a parasitic spore, like you would grow mushrooms with, a spore. It's a spore-forming protozoan, and it can get inside of us and cause disease, right? And so we have an infection where there's this spore in us, and it's doing bad stuff somewhere. And so it begins to affect the spinal cord in such a way that by just an infection, they ended up with damage to the central nervous system, and they ended up with central pain syndrome. Guma, which would be a small, soft swelling. So it's a swelling somewhere in your body. It's characteristic of the late stages of syphilis, unfortunately. It occurs in the connective tissue inside the liver or the brain or in the testes and the heart. And that guma, that little pocket of material, can affect 4 out of 100 where it presses on their central nervous system or grows to a place where it causes it. Then we have tuberculoma, which is a clinical manifestation of tuberculosis. It's like a firm lump. It can even have calcium in it. And it mimics cancer sometimes. They see this big chunk and they go, oh, we better take a biopsy on that. But tuberculoma, you have tuberculosis, there's this chunk. And that that infection can cause pressure again somewhere on the central nervous system and then central pain syndrome. And then I want to mention encephalitis. I could do a whole program on encephalitis because it's very complicated. But people's brains swell up for all kinds of reasons. They drain stuff off. They do whatever they can to help it. Sometimes they do the wrong thing. Sometimes there's nothing they can do. And I'm looking, I can say that to my friend Steve. He knows about encephalitis and the brain swelling up. And when it comes back, it causes all kinds of problems. It's very rare for people with central pain syndrome to have it in both hands. Usually one side of the brain's worse than the other, and that's almost always true. But both hands or both feet, without it going up and down the arms and legs, is unusual. If you can imagine, every time you use your hands, I don't want to imagine it, but encephalitis, the swelling of the brain, can lead to central pain syndrome. All these infections, about 4 out of 100 people. So you just look, what we do is we see who's done good research. How many people get this infection in a year? How many people are there in the world who have this infection? And then we have our 4% number from our CPS doctors, and we begin to create algorithms. Pretty soon, friends, if our research goes ahead, we'll have some algorithms where we could say point it at a city. Let's say, we point it at Kabul in Afghanistan. And we say, okay, our best guess is in that city with this many people and the other stuff we plug in, there's probably this many people with strokes, this many people with spinal injuries. We start to adjust because it's a crazy place. But you could take a regular country like Belgium, and that's what we're going to begin to do and work towards. That makes our numbers stronger. And I want to talk about having offices, which is really somebody who cares. It's not an office like we rent a place, but somebody cares in Belgium, and they want to be online, and they want to find other people, and they want to get information to Belgium. That's what we'll be doing. So that's why we point the algorithm at the country, and we can begin to say in Belgium, this is what we think. But infections, okay? And then where we're going to end up today is on tumors. Oh, one of my favorite subjects, because I actually had what could be called a little tumor. Mine was a blood tumor. But tumors are the fifth thing out of our list of about 10 or 12 that really comes down to, you'll find if you go back and you'll see it on the document I prepare. I'm calling it a catalog of etiologies. What are the 70 causes of CPS that are well documented in medical science? When you look at the list, you'll see tumor on there as the fifth one. So we talked about, see if I can remember, we talked about lesions. We talked about trauma. We talked about infections. Come on, don't get away from me. We talked about inflammation, and now we're talking fifth about tumors, okay? Tumor is an abnormal growth of tissue. It's tissue that does abnormal growth, resulting from uncontrolled or progressive multiplication of cells. It serves no function. It's a neoplasm. Cancer causes tumors, right? So it's some chunk of stuff that's growing. We don't like it. It could be a swollen part or a swelling on an organ or just a part of us. It could be a swell or a rise of any kind, a tumor, and it affects us in a bad way. I don't have the total percentage of all the people who have CPS, how many have CPS because of a tumor, but I can tell you there's some very important areas we're starting to learn about in our closing few minutes why we have tumors. First of all, we have gliomas. So the central nervous system basically has two kinds of cells. There are neurons, which we all know about. I call them the sexy cells because all the research has been on neurons. But 70% of the brain is made up of glial cells. So 30% is neurons. They're doing all the fun work. They've got electricity going through them. Then there's all these little glial cells. They're kind of dumb. They're just bumping around. They fill up the rest of the central nervous system. And the problem is when you get a tumor amongst those glial cells, right? Glioma, and neuroglia, there's these non-neuronal cells now that are in your central nervous system, and they've got a problem, right? They're beginning to grow in a way that's uncontrolled, and they're not forming homeostasis. They're the ones that help us to make sure that our axons are covered with fat, so the electricity stays in the circuit, and all these sorts of things. We're going to talk a lot about glial cells because I think all kinds of brain issues now, even Alzheimer's, all kinds of mental issues like schizophrenia, we're beginning to learn that we've been trying to fix it by even pain, central pain syndrome pain, friends. They've been looking at the neurons to fix it. And now they're starting to look at the glial cells to fix it because what they're finding is it's the glial cells malfunctioning. They're not cleaning up the neurons. What they do is they go in and they clean up between the synapses. They take away some junk. They hold everything in place. Like the glial cells are what's holding the neurons in place. 70% glial, 30% neurons, they're holding everything in place. Now they're growing out of proportion. They're a tumor. And so they begin to push on the neurons and cause all kinds of issues, okay? So, you've got glioma, and that causes tumors in the glial part of the central nervous system. It presses on the neurons, and then central pain results. Meningioma, also known as a meningiomal tumor, is something where the meninges, which is the skin sort of thing, it's the membranous layers that surround the brain. There's the meninges that surrounds your spinal cord. When you start having infections, when you start having inflammation, when you start having any kind of issues in your meninges around your brain or around your spinal cord, you're in trouble. If it turns into a tumor, something that's growing on its own, doctors will probably pick that up with an MRI or a CT or some way, and then more detail. And they'll say, we got to keep an eye on this because we can't let this thing grow. It'll cause all kinds of issues. And so there's meningioma. A third thing would be an intratumoral hemorrhage. So let's say just inside your brain, it's easy for me to point here. I want to say in the future, and I'll take these and fix them with all kinds of illustrations so that you'll actually see the data instead of my face, okay? I'll do a little bit of editing on these, but anyway, there's good data that we want to show and good illustrations that eventually we'll show to illustrate these things. But anyway, if you get a tumor inside your brain, a terrible thing can happen inside that tumor. It can actually bleed inside the tumor. So we would call it intratumoral hemorrhage. So there's a hemorrhage in the brain. It's not actually in the brain cells. It's in this chunk of bad stuff that's growing, glials or whatever it is. And there's a hemorrhage or cancer. And now there's bleeding inside the tumor, and that begins to affect the brain. There's pressure. Then there would be a neuroepithelial cyst, okay? So there's a membranous sac or cavity of abnormal character. So neuroepithelial, it means it's happening in the wrong side, usually on the left side of the brain. A colloid cyst, usually they develop between 20 and 50. I found it interesting, like one illustration, if you think of like a really bad pimple on your nose, because they will grow, like a lesion can happen outside, lesion can happen inside, tumor outside, tumor inside. Things poke out of us and look nasty. Well, this kind of neuroepithelial, if you get an epithelial, it'll be like a bad blister. It gets really bad and gross on your skin. This is like having one of those, like a lesion is a scab in your brain. This is like having one of those, only it's up in the neurons, right, or somewhere in your body, and it has this abnormal fluid, and so it's growing, and that can cause a bad problem, a cyst. So there's a cyst. It's like a sac. It's filling up. I have a cyst around my first. I have a bad disc, and I have a cyst around my first spinal thing down there, right? So anyway, there's these cysts. They're benign tumors, and they appear usually in the third ventricle. That's what's weird. Between 20 and 50, they appear in the third ventricle, in the anterior, so on the back of your brain, a certain place. All right, so I'm naming things because their doctor might say, hey, you have a neuroepithelial cyst. Or the doctor might say, hey, you've got a ruptured epidermoid cyst. And the list that's published at the Central Pain Syndrome Foundation and there at our Facebook group will have all these 70 things, but written in plain English, not doctoral language. There won't be the name will be there, but then simple English. And you'll be able to go down the list and say, yep, that's what they said I have. Or, that's not what I have. It's not on the list. But today we're building the list just by talking, okay? A ruptured epidermoid cyst is almost likely like a really bad or kind of zit growth, but it happens at the brainstem. So you can get like a zit in your brainstem or in the thalagal area. It's the same kind of thing. Epidermoid, it's like, the epidermis, the skin, but it kind of goes in the wrong direction and gets really bad. There's a lot of bad things that can happen that end up causing central pain syndrome. And so, friends, we've got just a few minutes left. I'll just talk about it really fast if I can today. We talked about the things that cause central pain syndrome, and we gave the first 5 large categories out of about 12 categories. We talked about lesions, which are strokes or bad tissue, both in the spinal cord and the brain. We talked about trauma. We talked about inflammation. We talked about infection. And we talked about tumors. And all these things make up a pretty significant portion of the people that have central pain syndrome. Something bad happened. They got some kind of illness. And when it was all done, there was something wrong in either their brain, their brainstem, or their spinal cord. And they had this weird, bad, terrible feeling. And so what we're going to talk about next month, hopefully, is the spinal cord. And it's 25% of us, but that's the most significant group after brain, after stroke things. And what makes it interesting is there's probably 20 kinds of different things that can go wrong with your spine that end up with CPS, and then a few other categories. And so it's been a fun for me. Folks that know me a little bit know that I joke around a lot, and this is kind of serious because what we're trying to do is just for the Central Pain Syndrome Foundation and folks around the world now who come to our YouTube channel, or they come to our Facebook place, or we have about 5 platforms going now, from everything from Instagram to many other kinds. We're trying to spread out so people know. But that's what we're trying to do, get the information to you. If you want to listen to these little discussions, you can know most of what I know. This is like the textbook being explained as best I can. We'll do these things again. I'm going to do one on a platform soon, sort of a TED Talk, and that will have a really basic 5-minute introduction, 13-minute. It'll be broken down into different chunks because I know an hour is a lot for folks, but we wanted to have a comprehensive, to start out with a comprehensive look at what is central pain syndrome, who does it affect, how does it affect people, what kind of illnesses now, the 70 etiologies or causes of central pain syndrome. And we'll be continuing with that probably one more month. And just wait, friends, it's coming. We're going to talk about treatment probably for about 3 months and really go into detail, because what we need to do is begin to talk together about what's working and what's not working, and then seeing if we can make those things spread to more people. And then we go back to the doctors and we begin to have some research that makes it so that more people can get a hold of what they need to deal with the pain. All right. My name is Scott Fontenot. It's been a good hour. My friends who know me well, they know I get nervous, even though it's funny. I was telling someone I was on television in Vietnam and probably about 10 million people were watching. What was funny about it is I got kicked out of Vietnam, right? I won't tell you why. You'll have to ask me in private. But after a year, I was able to get back into Vietnam, and I was supposed to lay low. That's what my boss said. Just don't talk to any important government people just lay low. Well, the last day I was there was December 1st, and it happened to be World AIDS Day, right? And so a friend of mine, he's a doctor, but he was also a very important government official. He was not part of the Politburo, which is like, the Central Committee. He was not part of the Politburo, 12 guys in charge of Vietnam, but the Central Committee was like 120 people. And he was in charge of AIDS for the whole country. And he called me and he said, we're having a parade tomorrow and I want you to come. And I said, Dr. Pham, I don't think that's a good idea. But he said, no, I insist. So we went to the parade and they had, prostitutes and drug addicts and orphans and widows and my kind of people that we took care of. And it was really interesting. I ended up sitting next to the mayor of Saigon. And when she found out I could speak Vietnamese, it was funny. She said, your Vietnamese is excellent. I was having a little trouble with my chopsticks. The mayor of Saigon was giving me a little food. And I thought, well, this isn't so bad. It may be on TV. A camera came up, right, and pointed at us. And I went, oh, no, this is terrible. And so we're on Vietnamese national TV and, 10 million people. But the worst part, I'll finish with this. I get home back to Bangkok and my sister calls me and she says, Scott, you're on CNN. This is awesome. And I just went like this. And when I told my boss the story, I tried to make it as funny as possible. Like, Ron, I didn't mean to be on Vietnamese national TV, hanging out with the mayor of Saigon. I didn't mean to be on CNN. But friends, I'll tell you one thing really cool. Because I met the mayor that day, we were able to put a $500,000, it was a surplus heart catheter lab into the poorest place in Vietnam, in the poorest part of Saigon, a really dense city where the hospital is really poor. We were able to put in the first catheter lab and we were able to provide training for 2 years. All that happened because I made a mistake and ended up in Vietnam. But the story is to tell you that there were about 6 of you watching, and I may have gotten more nervous about this than accidentally being on CNN. All right. I like to finish. I should tell more stories. Maybe it's more interesting. Usually that's all I do is tell stories and throw a few statistics in. But nice to see all of you who are here. Molly and Mark, Gail, Steve, a lot of nice folks still here. Now you know me a little better. You've seen me talk for a while. This 1 hour will be preserved and placed in several places. All right, everybody have a good weekend. I'm going to get that kayak in the water. If I have to get my son and son-in-law to carry me down and put me in the water, I'm telling you that kayak is going in the water this weekend. All right, that was fun for me. Hope you enjoyed it. Bye now.